for joining us. And I'm going to hand over to you to give us an update in your words, what's happening. And to start the ball rolling, I want to acknowledge that we have seen and we have shared publicly the new measures that you would have signed off on that has been gazetted. That is the COVID-19 restrictions for 1st to 30th of September that now reduces the curfew even further. So over to you, Minister, to talk us through what might have been some of the more emerging issues that you want to share with the nation.
Well, there are quite a number of things that we've been trying to do. One, as you know, we have been trying to increase our capacity in terms of testing. That really is still, for us, a major challenge because we have one national public health lab, so to speak. And we are now trying to increase the capacity there. The last time I was here, I was telling you that we were probably doing maybe about 60 tests or so. These are the PCR tests. We have increased that substantially, so now we are able to do close to 300 when we do 3 shifts. Prior to that, we were only doing 1 shift, and therefore we were very limited in how much samples we could have processed. We still need to increase further, and that is why we are in the process of sourcing one of the automated machines that can reduce the processing time. So Cabinet has agreed, they have provided the financing. We have reached out to the company and we are in the process of procuring that machine to reduce the processing time. And hopefully once we get that, we'll be able to process more samples. I think one of the major concerns that people have is this whole issue with the backlog that we are having. And I think that stems from a couple of reasons. Prior to all the cabinet members getting tested, there were a lot of stigma, I think, that was attached to people getting tested. And not a lot of people wanted to come forward to be tested because of that stigma. So with people seeing cabinet members being tested and so forth, it probably helped to alleviate maybe some of the fears that they might have had. And then the second thing that happened was that in terms of when you get tested and if you tested positive, there was only one recourse really. And that was that at some point, the team would have come and taken you into an institution where you would have been isolated. We have changed that somewhat, and we have been working 2 systems in terms of the isolation. Self-isolation and institutional isolation. And again, I think that has contributed to alleviating some of the fears, because I know when you only had the option of institutional isolation, there were people who had all the typical signs and symptoms of COVID, but refused to get tested because they were fearful that if they get tested and they were positive, they would have been taken away. So I think these factors have helped to drive the increase in testing. And as we increase testing, we are seeing more positives. And that really is why you're seeing so many cases popping up now. So that's one thing. Right. And we need to get better at testing. Right now, we have a backlog of samples. We have about 1,800 samples in a backlog. Today, we have been able to send off 500 of those samples to CARFA, who has kindly agreed to assist us. So that is going to help us to clear some of the backlog. But every day, when we clear off maybe at 250, we get back 300 samples, right? Wow. So we are in that constant kind of, we're almost stable in terms of having these numbers. Now, we have been looking as an interim measure until we get the new PCR machine in to look at not only CARFA, but other laboratories in the region to see whether we can send them samples and whether they'll be able to process that. So we have been investigating a number of options, and hopefully once we are able to tie up those arrangements, we would in the interim send some of those samples overseas to be processed.
Right.
So that's with testing. I mean, we are making a lot of efforts to try to increase that capacity, but these are our realistic challenges, you know, and we really are trying to figure out solutions of how to deal with them.
Correct.
Apart
And Minister,
that,
I guess,
yeah.
Go on.
No, you ask your question and maybe
Well,
I'll let you.
Yeah, I was going to ask you, when you send the samples overseas for testing, I guess the bottleneck there is to get the carrier, well, to get an airline. But
Yeah.
do you wait for a physical return of a result, or is the result transmitted to you electronically?
Electronically. So once we get the samples out and they're able to process it, they'll then send back those results to us electronically. And CARFA has a very good lab. They have been the regional laboratory facilities. So they have all the expertise there. And from time to time, we also would consult with them on issues that we might be having locally. So they're pretty good. And in some cases, we also send our samples there for validation, because you want to make sure that what you're doing here is also validated. So we would normally send samples to CARFA as another way of validating that what we're doing here.
Perfect. That is good, Minister. In terms of the numbers and the way they're rising. Sorry, you have been breaking up.
Yeah, you're getting me?
Yes.
Yeah,
yes, I'm getting.
Okay. Yeah, you were just asking something.
Yeah, I was asking you the following. With regards to numbers and the way they have come, based on some numbers we saw last week, we were at, I think, one of every 4 persons tested was positive. If one was, would that be a fair assessment of a geographic sample rather than the direct sampling, that direct testing you have done? Can we say, or is it too premature to say that maybe 1 of every 4 Guyanese is at risk at this moment?
The test results are showing, approximately that. But the test results, because again, we are not doing enough testing. Because the demand for testing, if we go out, I mean, the 1 in 4 would depend on the denominator. But in a way, that denominator is constrained because while we have opened it up, we are seeing more people who would have displayed signs and symptoms. We have seen more hospitalized patients. We have seen persons who believe that they were somehow exposed coming forward. So even in that denominator, it's kind of a restricted group of people, so to speak, because the average person who don't feel they have the signs and symptoms are not really coming forward. So we are actually operating with a group that feel they're at a higher risk of COVID. And maybe that 1 in 4 might not reflect the actual reality. Now, if we are able to do more widespread testing, then that denominator would be larger and you would have a larger pool of persons who would be negative. And so that positivity number that people have been talking about would come down significantly, right? But nevertheless, it is a good it is an indication of what is happening. This also varies by region because there are regions where we'll see increase in cases, and there are regions that would not have so many cases. But again, as we expand testing, we will see that type of picture changing. And right now, we have supplied all the regions with enough test kits so that they can actively involve in testing.
Oh, that's good. So that is a real positive thing. Go ahead, Leonard.
Yes, and if I may, Minister, do we have a time frame in which that machine, that cabinet has given the approval of, how soon it's likely to be here?
We're working hard to get it in. I don't want to give you a time frame because sometimes with the best of intention, we'll say maybe a week, 2 weeks, and then something come up, and then people are judging you by not being able to deliver that. So what I want to say to you is that we're making every effort to get that in as quickly as possible.
And those death rate, those numbers, the numbers, I think it's about 15 to 20 persons died just in the month of August alone. What are some of the conclusions that we getting from that?
A couple of things. One, and something that we need to understand. About 80% of the persons who would have tested positive would have maybe no symptoms or very mild symptoms. They do not require hospitalization, right? And then you have maybe about 20% of those persons, or the remaining 20%, what we'll term maybe severe cases. They would require some form of hospitalization. And of them, maybe 4 to 5% who are going to be critical patients would require ICU care, right? And those who would be in the ICU, they have a higher risk of, a number of things are happening there because they would have the more critical or severe form of the disease. And sometimes it can be very challenging in managing them. Now, globally, what has happened, persons who would have more risk would be older persons. And our mortality profile is showing that quite a number of older persons, when they get COVID-19, would have that type of risk. So we are seeing that here too in Guyana. And then we have a number of persons who would have passed away, also had other comorbidities, other conditions. So that too has been a challenge. And then, as with elsewhere too, we have seen younger patients, relatively young patients. And explaining those deaths are a little bit more difficult because in many cases, they would have been relatively healthy people. But one of the things that we know is that the immune system of some persons can react adversely to this virus, something that in the medical jargon, they talk about a cytokine storm and so forth. And when you have those types of adverse reaction, sometimes those persons would have a more difficult time recovering from the disease, right? And maybe that might be an explanation for some of the younger person who we really thought might have recovered. But the profile of deaths that we're seeing in the hospital does not differ from what is happening globally, right? But that profile is similar to what we're experiencing here in Guyana.
I have one more question for you before I hand over to my good host. Minister, somebody called me and they said that one of the other hospitals or one of the private hospitals offering blood tests. Are blood tests an acceptable form or something that could be dependent on for COVID-19?
The gold standard for testing for COVID-19 is the PCR test. As far as I'm aware, that is being offered by the government at the national, well, we can swab at different places, but eventually it's processed by the National Public Health Reference Lab, right? So we have different sites where we are taking in these samples. And that is the sample where we put the thing down your nose and swab you, right? So there's also Eureka that I think is offering it in the private sector. I'm not sure if any other hospital is actually offering that type of test, right? So what you have, there's some other places that are offering something called a rapid test. Now, rapid tests generally in 15 to 20 minutes, you can get a result. there are two types of rapid tests. Those that look for the antibody, and antibody would appear after you would have gotten the virus in your system, and your immune system would have worked to make this antibody. So that process is a bit delayed, right? Sometimes it takes maybe a week, week and a half, or even later for you to see, after you have been exposed, for you to see the manifestation of antibody. And it has to be at a certain threshold before these tests can pick it up. So sometimes you can be positive if you test with a PCR, you're going to show positive. But if you use the antibody test, you would be negative because it hasn't, your body hasn't reacted to make the antibody as yet. So that delayed reaction in making that antibody can give you a false sense of security that you are probably negative. Now, I know of some cases where people would have come, they did the PCR test, they were tested positive, then they went and they did the antibody test. They really don't know the difference or the science behind it, and they got a negative test. And then they would probably claim, well, you know, you guys are not doing a good job. But there's a real big difference between the type of testing, right? Now, there's another, apart from antibody testing that are rapid tests, there's also another form of rapid tests. And that actually would test for the virus. And some of these systems are called point of care systems. Some of them maybe take 20 minutes, 45 minutes. And there's a special machine that would be able to do that. I don't know how much of that we have in Guyana. I saw this afternoon that one institution in the private sector said they're offering that. I haven't been able to get the kinds of information to basically say whether, you know, that is meeting the kinds of standards that we would like. I don't know as of this moment. Right? So for me to give you a proper answer to that part of it, I would need to get some more details. So I don't want to venture an answer without having the information at my disposal.
No, it's exactly the same reason why I asked you that, because people were complaining that they tested positive and then they went and they did the other test and they tested negative. So I'm glad that you really ventured into that. And maybe before handing over to Yog, sorry with that, Yog, are we contemplating at this point in time maybe some other measures, including a total lockdown?
Well, as you know, the new order would become effective from midnight, well, tonight, and then it goes until until the end of September. We will monitor and see what goes on. As you know, the basic thing with this disease, it is one that happens because of person-to-person transmission. And if people stay away from each other, then the virus can't jump from one person to the other. It's as simple as that. And the measures that we have put in place is to try to reduce person-to-person interaction. That's the logic behind all of this. It defeats the logic, however, when people ignore everything in there. Because look, at the end of the day, it comes back to people taking on responsibility. We can't have a policeman everywhere to try to tell people to do the right thing, right? So the logic really is to limit interaction. And we recognize that maybe persons were feeling that, you know, they can go about and be as if everything is normal. If we do that, we are going to encourage the spread of the disease, because in a lot of cases, we don't know who got it and who don't. Right?
Correct.
And if you're not abiding by the rules, then you're going to be part of the whole thing of spreading it. We are hopeful that since we have gone back from gone to 6 p.m. to 6 a.m., that we will reduce some of this interaction. A lot of people, and you would know this because you know, we allow takeout food, right? But people go to these places where food are sold and they're all congregated there, no social distancing.
Right.
Some people even want to go inside the restaurant to eat. Now we know that transmission can be increased if you are in indoor environments. If you are in crowded indoor environments, it's worse, right? So the logic here, we're trying to get people to understand the logic behind how this thing is spread, and hopefully by educating the public that we can help to reduce spread, because this really is really about people's behavior. And if everybody do the right thing, then I think we can make a big difference.
Correct. So, Minister, I know you got to go. You have a very tight schedule. Just a couple short questions for you, if you don't mind, sir.
Sure.
The COVID task force, as it were, is there an overarching COVID task force for the country that is not just health, but across the spectrum? And who is the head of that COVID task force?
The Prime Minister is the head of that. And
Prime Minister.
Yeah, we have, as we had said before, we have a number of persons on that. Myself, Dr. Ramsamy. We have a representative from the private sector, and we have PAHO. Dr. Adikro is there. We have the representative from the UN, Mikiko, and we also have a representative from CARICOM. So we have that blend, that mix.
Great.
And so that's the
and would you be able to say, would you be able to say whether the task force is contemplating any fiscal relief, or that should be left to the PM?
So under the task force, what we have a health component that does the health response. And then we have another component that is looking at the socioeconomic side of things. Right? That subcommittee, if you like, has been working and coming up with a number of measures. We have actually reviewed, because we have received submissions from the private sector, from the banking sector. A number of organizations have actually submitted very good proposals to us. And we have been able to pull some of that together. And we are working on some strategies of what is possible and what we can do. The president spoke about the $4.5 billion. Some of that money would utilize to bring some relief measures. And we are also in negotiations with the World Bank, with the IDB, with some other financial institutions to get some financing to put some of the measures in place. So it's a work in progress, and you know, we are really pushing to see how we can bring relief.
Understood. Because as you're aware, a lot of people out there are also are under some real severe financial constraints. People are unable to pay their banks, their mortgages, and stuff are becoming due. They're now working. And you know, while 3 months ago the bank said, well, you could defer your payments for 3 months, well, those 3 months are now up. Whether the central bank is relooking at rates, whether rents and mortgages can be looked at, we're certainly hoping that, and Leonard, maybe it is something that we can reach out to the head of the task force to see whether we can get some questions. Minister, some more COVID-related questions, just 3 more I have for you. One understands what you say. A lot of us, we try to follow. The comorbidity issue is telling, and it really impacts the mortality rate. But in terms of the mortality rate, Guyana, given the numbers we would have seen, we're almost at 3%. Isn't that a little bit high compared to other countries?
We're not fully 3% yet, but we're there 2 point something.
2.9, yeah, 2.9.
You guys are.
But these things, you know, look, it's an evolving epidemic, right? And sometimes, some weeks it would go up, some weeks it would be less. we actually would have preferred that we don't have any deaths. You know, we have a medical team that is really working to ensure that we try to prevent as much deaths as possible. One of the things, and to really improve the care that we are offering, that is why last week, one of the things that we had was a clinical group that we brought together. And we want to standardize the kind of care that we are offering in every region. So Dr. Carpen and a number of the other doctors at GPHC have come up with some standardized treatment protocol for COVID. And we have brought in, well, we have done some training over the internet where all the doctors who are involved with COVID care were trained on these guidelines. We also must recognize that in the regions themselves, we do not have a lot of the type of ICU that are necessary to provide the kind of care for a critical COVID patient. Now we are trying to build that capacity, and one of the things that we have to do for the doctors in the outlying area is to ensure that they understand how to use the ventilators, how to provide that care, how to recognize when somebody is moving from severe to critical, and so forth. Most of the outlying areas do not have ventilators. As we speak, we don't have them. We have put in an order for them, and I'm hopeful that by this week, we will be able to get some of those ventilators into the country. We have started the training for the doctors to be able to use them, and we'll have a practical component where many of them would come into Georgetown to be trained on the practical side. And then, so when they actually get the machine, they're capable of utilizing that machine. So in terms of lifting the quality of care, we are working very hard to make sure that happens, so that, you know, hopefully we can see more of the patients closer to their place of home and provide quality care. And that's our intention, and that's our goal.
Gotcha. Two questions more for you, sir. One is, you know, a lot of persons who might be looking towards whenever government is having repatriation flights, they want to take advantage of that. What might you advise them that would be the period of time between test and result to allow them to take advantage of a repatriation flight?
If I had my way, I would have said 48 hours, but that really is not practical. Because we know in the United States, where a lot of people are coming back or want to come back from the US to come back home, many of them have told us that they get a challenge in getting their PCR done within that 48 hours time frame. So we have, in a way, relaxed it and allow for a 5-day period. And even with a 5-day period, a lot of people are finding challenges. Now, one of the things that we have been looking at is that we want to, we have a working group that is looking at when we can open the airport, what are the measures that we'll be putting in place. One of those measures would be that when somebody come into the airport, despite them having a PCR abroad, we would also want to be able, so that when they come in, we can provide them with a PCR test at the airport and be able to get that result maybe within an hour, 2-hour period. So while they do the rest of the processing, before they leave the airport, that we should have the result. And so we would know that they're negative, right? So we're not there yet. Yes. That's our intention. And because we want to ensure that people are safe. And therefore, we have been having these discussions, and we are working to put some of these mechanisms in place. So when we reopen the airport, we have the mechanism to ensure that persons coming back stay safe, and when they leave, they can leave here, and that we can go to other countries too, and they can accept our protocols and our results. Because as we move forward, you know, this thing is all interconnected. And there will be regional standards that eventually would come into being.
Of course.
And if you want to leave Guyana to go to Barbados or Trinidad or something, they would want to standardize the protocol. So whatever we do here would have to be in sync with those other countries.
Of course. Indeed, Minister. And Minister, my last question to you is, would the ministry, would you, sir, consider at some stage designing such releases to the public that will educate us about demographics, where people would know what areas, specific areas is more at high risk and stuff like that? Shouldn't that type of information be something the government could consider?
We are getting there. It's a very good question because, you know, over the last maybe week and a half, you would have seen our dashboard being, you know, up and down with some numbers. That's not because we don't want to issue numbers, but we have had our own challenges with our technical people and issuing these releases and so forth. So we are trying to put the technical and the PR people together, and so that we can ensure timely release. So one of the things that we are aspiring to do is to get out that dashboard by 4:30 every afternoon, and then by 5:30 to have what we call an explainer, so that if there are numbers in there, it would explain what these numbers represent, our interpretation, our analysis, and so forth. So it allows anybody that is viewing the dashboard to interpret the results that they're seeing. So we are going to start with that. We do have some regional data, and at some point, maybe not every day, we'll be able to release that. But once we get this dashboard up and running and that's working, then we'll work on getting out other bits of information. The regional one, as you can imagine, sometimes would pose a challenge because discharges and so that happen in the region, real-time information and so forth might not be as accurate as we want them. But nevertheless, we want the public to understand what is going on and to have information that they can relate to in their respective region. But let's get the general one in order, and then later on we'll move to get more disaggregated information, right? So
Correct.
we will keep working on it.
Thank you, Minister. Thank you so much for the update. And on behalf of the entire Guyanese public, we express our appreciation to you for bringing us this update, sir. And keep up the good work, you and your team. And from Room 592 to your entire team there, CMO, yourself, your family included, and all the doctors, especially on the front of this terrible disease. Our regards and respect to you, sir. Hats off, kudos, and great job. Well done, sir.
Thank you very much for having me, and we look forward to you helping us to educate the public. I think that's the biggest job that we need right now, because I think with good education, we'll get better compliance, and I think that is absolutely important. So thank you for having me.
Absolutely. Count on us. And the next time we have you, Minister, we want to move away from COVID and talk about mainstream health as well. But I know you're very, very busy with COVID. So we're going to allow this.
I think we can do that as well. Thanks.
All right. Have a great night.
Bye-bye.
Bye-bye.